All right, all. So you'll note, I'm sure you already have, that I did send you a study guide. I don't have, I would like to get this in before we leave for break. So uh, today we finished the blood unit, that leaves the heart unit next. To that end, so, um, let me see what I get covered. I'll know probably by Friday when it'll be a good time for that exam, and we'll figure that part out. So I did load two things. I mean, you have there's another outline. So I did load just the chapter we're going to be using, at least part of it, maybe part of the Marie chapter on the heart as well. We'll probably get a chance just to say hello to that chapter today. We finished the blood transfusion stuff, and I have a pretty full outline. It involves actually two. You see, there's like 13 pages of this relevant to the heart, both anatomy and physiology. Is about the first 4 or 5 pages. So it kind of ends maybe even 7 or 8 pages. Got here. When I started what's called chapter 19, the textbook changes the numbers all the time as they change editions, and I'll probably relabel that for you and put it separately. But once you end up with after congestive heart failure, boom, then then that's the end of the heart stuff. And this will all be on this will be for the exam after break, which we'll have both blood vessels and immune on that exam. So that's the logistics that are there. So I do want to get cracking on the blood aspect of things today and finish that unit up. So I ended here, and I'm using the Marie, which I've used. Clotting is clotting. It's nothing major. You're not going to see anything that's out of the ordinary in any textbook. It's all about safe. This is kind of where we start, and I'll redraw some of my terrible handwriting and things like that are there. The subject is transfusions, and it is. I don't think there's anything else to guys see. Uh, Transfusions very significant. There's a lot of misconceptions on transfusions. Most transfusions do not involve whole blood. It's not like in the movies where you see, someone getting massive amounts of what we call whole blood. The whole idea is that we have so many uses for that blood. And most of the people who receive transfusions of blood do it for one thing: oxygen carrying capability. For whatever reason, it's rare, thankfully. Normally, the only time we use whole blood is when we have someone who's had a major accident. So a gunshot wound, a stab wound, a terrible auto wreck. They're bleeding externally and internally. At that point, you have to replace all of the volume. So now you've got to literally replace everything because it's all pouring out. Most of the time, when people have chronic blood loss, when people have varying kinds of anemia, when we're doing elective surgical procedures, such as hips and shoulders, replacements, large plastic procedures, large cosmetic procedures of almost any type, there's a potential for a large amount of blood loss. And typically, what we're using there more than anything else is called packed cells. So it goes right back to the beginning of this chapter, when that whole thing about the test tube and centrifuging it. Just like the blood bank does, we spin the blood down. We have uses for all the components. So why use all of them when you typically only need to use the oxygen carrying capability? So it's easy. We siphon off the plasma because we have uses for plasma proteins, plasma in itself, clotting factors found in the plasma, etc. Boom. In the old days, when somebody had trouble clotting, we freeze it and we give them what's called FFP. Don't do it so much anymore. Fresh frozen plasma, what the acronym stood for. We utilize white blood cells. We do platelet transfers. So you siphon off that buffy coat, and you're able to separate them further by additional laboratory means. What does that leave? The red cells that are packed at the bottom. And indeed, you'll see in the PowerPoint, and it's absolutely true in a hospital sense, we call them packed cells, short for packed red blood cells. That's the typical transfusion that's given for people who are anemic, chronically slow, steady blood loss, which I'll allude to shortly. You give them that, and then you just compensate that with fluid. I mean, it's not just red cells. There's obviously fluid. It's a liquid component, even though it's relatively thick. And then we compensate for volume by giving normal saline. You'll see here they talk about something called lactated ringers, which is a solution that's also isotonic. You probably remember isotonic when we talked about that in AP1 being things that are neither going to cause cells, push fluid in cells or suck fluid out of the cells. We usually use normal saline. We use, I don't know if they use that much anymore. They use D5W, which is a sugar, dextrose 5% in water. And lactated ringer is something used a lot in burn patients. It's sort of like an intravenous electrolytically balanced material that compensates for a lot of things. So we see it in burns. And so I'm trying to be joking about it. It's almost like if one was sugar and one was salt. It's a mixture. It's almost like intravenous Gatorade. You want to think of it that way, using that kind of a balanced solution with a lot of chemicals in it that assist. And that's used a great deal. And depending on where you go with your careers, you'll see a lot of these solutions being used. But typically the transfusions are made of packed red blood cells. Understand, it's not so much the blood loss by number. So if you take this, affects blood vessels, and normally we do this, if it happens gradually, for whatever reason, even if you had a bad cut, and there was a fair amount of blood loss, but you got stopped, you got stitches in it. Okay, you're going to compensate. The blood vessels will spasm, the pressure will stop some of the bleeding. You'll be able to, once it's stitched up, your body will compensate. It'll say, "Oh, I've got a low number," and a healthy individual will compensate in a relatively short period of time, but only so much. It's a matter of how much and how rapidly. So 15 to 30%, when somebody gets that way, let's say look at 30% as the magic number, because more than potentially fatal shock. And I'll point out again is how rapid. So if you're 15 and you lose roughly a third, your hemoglobin goes from 15 to 10. 10 is a criteria that most people will not get a transfusion for. Most places will not transfuse you unless the number these days is under 9. Because we have Procrit and other agents that can help to without using blood, because you're giving, let's be clear, when you're giving someone else's blood, there's a potential for a reaction. It's like any other transplant. If it's not yours, you're going to have a reaction to it. The question is how severe the reaction. I'll go into what the criteria are and how we do this. 30%, more than 30%, potentially fatal severe shock, only if it's rapid. Between 1998 and first part, a 2-year period between roughly spring of 98 to spring of 2000, this individual who you are looking at, hopefully, had something like 50 units of other, maybe even as many as 75 units of somebody else's blood. I had chronic blood loss. I was seeing patients in the spring of 25 years ago, in the spring of 2000, with a hemoglobin of about 5 to 6. That's 2/3 of my oxygen carrying capability gone. I told you, I could barely make it up. I would have made 3 steps, but I was still functioning because it was chronic blood loss. It took a long time. I was getting transfusions probably every 3 to 6 weeks, a minimum of 2. You never transfuse 1 unit, you always get 2, at least, sometimes 3. And until we got a variety of things straightened out, what was causing it, insurance considerations, an opportunity to do the procedure, I was in big trouble. Big trouble. If you can imagine, for someone who was not yet 50 years old, having all of that done. That was in between my 2 major ulcer surgeries. So I know of what I speak, and that is my context for this. I was fortunate, because we're talking about blood typing, if you will. I have A positive blood. A positive is the second most common blood. O positive is the most common. They never, even after multiple transfusions, and every time you get someone else's blood, you form a reaction to it, and it makes it harder to find a suitable match the next time, or the next time, or the 28th time, such as in my case. And in all those times, the most it took was 2 or 3 days. Even if they couldn't find the blood in Pittsburgh by way of the blood bank, they have an exchange policy with the neighboring blood banks. The next closest, if you did not know, is in Buffalo, or was at the time. So I haven't had one in 20 years, so I'm, 25 years, so things may have changed. So there's a lot about this that's very, very, very significant that goes on. And we'll go into why that is. Why that is, when you're getting, it doesn't matter. We talk about an immune system. When you're getting anything from somebody else, okay, whether it's a transplant, there's always going to be reactions. The whole idea is to use criteria to minimize those, and that's where the whole ABO blood group / typing system. Blood group is technically A, B, O, or AB. We call it blood type. Now we add the positive or negative. That's classical. They use the terms interchangeably now. I won't ask you about that. But just historically. And here, that's the potential. I mean, when your blood volume is that low, and we look at shock, when we look at the cardiovascular unit and blood vessels, at that point you have such low blood volume that your blood pressure is so low that your heart is working overtime to try to push blood around to the point where it literally gives up the ghost. That's why it's life-threatening. So here's that mimicking plasma electrolytes. That's the ringers. Replacement of volume, it restores adequate circulation, but not the oxygen. That's why the combination of the pack cells and this have been used. And have been around for a long time. Before we knew anything about it. Back when I was learning about transfusions 50 years ago. 51 years ago. In school. The surgeon was speaking to us. He was a burn surgeon. He goes, I love pack cells. He goes, I've never had a problem with pack cells. Because he was telling us the same kind of a spiel. What they found out when they studied years later, 10 or 15 years later, pack cells, people who got pack cells rather than whole blood had less likelihood of getting hepatitis B or C and less likelihood of HIV. What we know now, we did not know then. The word HIV wasn't even discussed in 1974. Nobody knew what it was. That HIV travels with white blood cells. It affects white blood cells. If you're using pack cells, you've removed most of them. Could there be some HIV in there? Sure. But it's much, much less likely. And you'll learn a lot when it comes to infections. It's a numbers game. You can fight off one exposure or two, but not 100,000 exposures to be painted with a broad brush. The other, hepatitis, we found that it traveled in the plasma, particularly with the fibrinogen, the dissolved fiber component. So it traveled a lot with clotting factors. The fact that pack cells didn't have or had very little of either of those two was a big plus that we didn't even know about. So sometimes things are serendipitous. You get lucky. If you did not know, prior to 1987, people getting transfusions pre-1987 were at significant risk of hepatitis B or C and HIV because we had inadequate screening. Since 1987, that is not the case. The safest blood you can get is your own. And there are occasions where we do donate things if we're going to have an elective surgery, hip replacement, big shoulder replacement, cosmetic surgery. You put a couple of your own units on board and they'll store them. If you don't use them, the blood bank will be more than happy to find a way. Honestly. So, and there's nothing unusual about doing that. On the other hand, people make a mistake. They think for years, oh, I'm A-pos. My Uncle Joe is A-pos. I mean, he's donating blood all the time. We'll use his. That's called directed donations. I'm not saying anything bad about Uncle Joe, like he was fooling around and Aunt Mary doesn't know about it. So it is possible. We've had a couple of weird uncles in my family. Okay, joking. The idea is that statistically, blood bank blood since 1987 is safer than directed donations. Which if you have to get a transfusion or somebody in your family does, even though you have the same blood type, you can replenish the blood bank and basically say to them, so-and-so is having it, it's my uncle, my aunt, my mom, whatever the relation. Here's some blood, and it's almost like I'd like to put it back into the account from theirs. Do that. Because you know that your A-pos and their A-pos is not, don't give them your money. Nor should they take it. I don't think blood banks do that anymore, so we'll have a blood drive in there. We used to have it twice a year in the gym over there. See them in there all the time. If you're so inclined, give blood if you feel like it. If you don't have to. But I mean, it's a nice thing to do because of all my transfusions, I'm unable to do that. When they look me up on it, they go, nope, next. It was true. Even when I tried to be a platelet donor for my dad when he didn't survive open heart surgery, they wouldn't take my blood, my platelets, even though we have both rate positive. Just to give you an idea. So there's a lot here that's going on. So if don't be reluctant. The blood banks do a much better job. If you were in my micro unit, you would have heard the same story that I will tell you now. That my first wife, now we think there's one of two places she got exposed to hepatitis C. She either got exposed to Hep C when she was the nurse in charge, evening and weekend supervisor at a big nursing home in Wilkinsburg, the old Wilkins house. It's not there anymore. Something else, and there's like a senior high rise there, 120 bed nursing home. She ran the shop all the weekends. She would be drawing bloods. They had a patient who was drawing, got combative, spattered. She never wore glasses or eye protection. Boom. Probably it could have come in that way, but she did have a transfusion in '81 when they had tried to do an ovarian surgery and found out she had a variation of that von Willebrand's disease I was telling you about. And I think it's more likely that was the exposure. I think it was just fortunate that she found out because they had her go to occupational medicine, employee health, and be screened. This is back in 2004, 20 plus years later. That's my view. Okay, give you an idea. So whole blood transfusion, it's about rapid and substantial, the big accident. We use the PAC cells, and I mean that's the acronym. If you say PAC cells, everybody knows what you're talking about. And again, I think it varies. I think it's a good average number, about 35 days, maybe a little longer. Okay, probably ones that are types that are in need, but there'll be guidelines for every blood bank that does that. And this is the whole idea. Transfusion reactions can be fatal. Do not think for a minute that these mistakes happen all the time. It's everything you can do. Hospitals, anytime you're dealing with medical care, anytime you're dealing with hospitals, anytime you're dealing with tons and tons of stuff, it's easy to make mistakes. If you did not know it, okay, it's easy. If you have an IV, all you have to do to give that transfusion is hang that bag of blood up there. There's a needle at the end of it and plug it into the already existing IV. Anybody could do it. The reality is it takes two people to do it legally. So that's a famous question. How many people does it take to hang blood? Minimum of two. You have never, I have all this. Two people would come up when I was getting a transfusion. This is 25 years ago. Imagine what it's like today. How many times they would ask me who I was, check my ID, check the number on the blood, check the number on the order. And they have to sign off. Each of them would have to sign off. Each nurse would have to sign off in a place separately. So you had a minimum of two signatures on at least a half dozen documents. And then someone could hang the blood. I mean, it's easy enough to do. The physical act of doing it, it's going through all that to avoid the potential immediately life-threatening mistake. Oh, well, that can't happen a whole lot. I'll give you the same anecdote I've been telling for the last 20 years. Any hospital, Duke University Medical Center Hospital, top 10 in anybody's listening in the continental United States. They had, in the days when you had a very limited, now liver transplants are different. But at that time, somebody would die, they would harvest the liver if they were a donor. You had 24 hours to get that liver, preferably 12, to whoever was a compatible donor. They would jet it, and they had someone on, just like they have here, it's called the CORE, C-O-R-E, here at Transplant Central, which UPMC has been for years. And down at Duke, they have a similar thing. They had a match for this liver. The liver came down just as they got on the tarmac at wherever Chapel Hill Durham Airport, whatever the name of that airport is in North Carolina. They got a message or a cell phone call back, so-and-so, Mr. So-and-so just died. At that point, they had to find a match for the liver. They quickly looked online on their network of people. If you're waiting like for that, you have to be within a half an hour on beeper or on cell these days to get to the hospital. They found a young woman with some kind of liver disease in her 20s would appear to be an exactly compatible liver. So they called her in, prepped her, transplanted her. Operation very successful. 3 days later, she died. Duke, they made a mistake, not just an intern, not just a medical student, a high school student, and a middle school student would have said, did you check the blood type? In the haste to do that, nobody checked the blood types. It was one of those, she was A, the liver was B, or the other way around. Duke. Could happen at Harvard, could happen at UPMC, AGH, pick one. If you go into healthcare, you will hear mistakes that will be amazed. Operating on the wrong person, operating on a right when it should be a left. We had one where somebody was supposed to have a bunion removed and ended up having a hysterectomy. Try that. I mean, all because people didn't check. They're in such a hurry. The moral of the story: be careful. There's always mistakes. There's med errors. Make them little ones. Be on top of it. You learn when not to cut corners, because unfortunately, when you're in healthcare, particularly, you're extraordinarily busy. I mean, you're just hoping that you don't have an admission, a death, an emergency, somebody go critical, because then it's like the whole world's going crazy, and you're trying to keep it all in focus. This is one of the hard parts for a lot of the career path that many of you have chosen. For those who are not on that career path, fine too, but life is like that. You know, it's that Murphy's Law thing. Anything that can go wrong will go wrong. It usually does go wrong. So make every effort to Murphy-proof what you're doing. On with the show. So it's all about these, we call them blood groups is the better name. This is your introduction to immunology. The next giant chapter we do after the heart and blood vessels is immunology, after the break, after spring break. It's a monster. Antigens, antibody generating is where we join the term. They're not foreign. Okay, now we have self and non-self antigen. When you're born, your mom's antibodies cover you for 6 months. As your immune system develops for those first 6 months, it's identifying self and non-self. So once it recognizes your antigens, you're good to go. Anything after that wasn't there to start doesn't recognize, and it will attack vigorously. So antigen, it's not just anything perceived as foreign. After that would be a foreign antigen. They really should be more thorough and say self-antigens. So red blood cells, they call them agglutinogens, because if you ever tested your blood and finger pricked it and put it on that little card, the little chemicals on it, and it's speckled, that's called agglutination. That's one way antibodies work. The antibodies latch on to the red cells. There's so many of them, but they're tiny, they form that little speckled pattern. That's called agglutination. That's something antibodies do. It's not unique to red blood cells. So they gave them a fancy name. I don't care about it. I just call them antigens. So the problem is, if it's transfused blood, it's potentially fatal, because what will happen, it will cause those red blood cells to break apart, not unlike you do when you do the finger stick test. And it'll end up with clogging your kidneys, and your kidneys will shut down, and it can be immediately life-threatening. And I'm talking about immediate, we're talking about you better do something right now. So we have a lot of these on our red cells. We are only concerned really with the 3 most vigorous ones. When you hear about, for instance, with me, when they had to do a transfusion, they do what's called a cross match. When you cross match, you test for all of these. You're trying to find the best possible match. Sometimes it's not there, but you still are relying on that one, whether it's APOS or OPOS. Now, once you have that, we start looking. So maybe if there's 30 and you're good with 20 of them, you go, okay. Unfortunately, every time you get a transfusion of somebody else's blood, it gets harder to match. And that's, like I said, only one time that they have to go outside of the area. But rather than having a match in an hour, I used to have to go get my blood taken, and they'd call me 2 days later and say, hey, you can come in, because we have your blood now on board. The blood bank just got it. Okay, cool. So, and we use this, and there's all of these, but they're relatively weak. Okay, so we use the ABO ones and the RH. They are not the same. The ABO is a unique system. Okay, and again, the transfusion reactions are vigorous. The RH system is standard. I wrote it up there, Mendelian Genetics 101, dominant and recessive. The ones we've all learned about. You say Mendelian, and you have positive, 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 negative, negative, positive, or two negatives. That's it. 4 choices. Result is any 3 of those choices is that you're going to be positive, because positive is dominant. The reality is why we see 80 to sometimes as much as 85% of people positive RH factor is positive people are more likely to mate with and have children with other positive people statistically. And it increases the likelihood statistically that they're going to have positive offspring. Okay? That's just the way it works. And that's true for a lot of things. So you have to look at the numbers that are part of it. So it's on. If you have, trust me, if you have an RH negative blood and you've donated blood, the blood bank. If you donate blood, if you're a regular blood donor, once you donate, the blood bank is your best friend. They will text you. They will call you. It'll be like you haven't had a date for a while with them. They're going to want you to come in all the time. And if it's negative, they're going to really want you to come. They're going to be in close contact with you. So on with the show. The 2 antigens, A and B, okay, are surface markers. That's all they are. An antigen is a short chain of carbohydrates that sticks out of a protein on the membrane of the cell. You learned about this in AP1, okay? And you'll take a look at this. And they call the antibodies. Now, understand, people have a mistaken notion. This is another immune system little fact. They have a notion that, oh, you only make antibodies once you've been exposed. Not true. We are pre-programmed to make certain antibodies. If you have, like me, type A blood, you make antibodies to fight B. Depending on who your parents were and where they came from and what their lineage is, geographically, whatever the politically correct term is for what they, ethnicity, things like that, region where they grew up, your body develops pre-programming and makes certain antibodies because it prevents you from getting diseases that are common. I told my micro class about something called rotavirus that my 10-month-old son got, and we nearly lost him. We went to San Antonio. That is indigenous to the Rio Grande area, southwestern Texas, northern and Rio Grande area, Mexico. Folks there are genetically, they have antibodies, they're pre-programmed, they're born with it. They don't get it. So your immune system is a very interesting system in that regard. So if you have type, and you'll see this in a second, you have type A blood, you have antibodies to B. If you have type B blood, you have antibodies to A. Needless to say, A and B is a very bad match. They just don't mix well. And so as you can see, these antibodies form in the blood at about 2 months of age, and we reach the dose level of 8 to 10 years. It's a pretty good graphic. And it gives you the idea. What's unusual about this system, it is not Mendelian genetics. Something called multiple alleles. Dominant and recessive are an allele pair. That's typical. Whether it's hair color or eye color or, whatever, dangling ears or undangling ears, freckles or no freckles, all those things you probably learned about in basic genetics. They're kind of niche, hitchhiker's thumb, all that. That's Mendelian genetics. This is not. This is called multiple alleles. And what makes it multiple, you have 2 dominants, equally powerful, called codominant, and you have a recessive. So what you have here genetically, AB, you have 2 dominants. For B, you could have B, 2 B's, or B and a recessive. For A, you could have 2 A's and A and a recessive. And for O, you'd have to have 2 recessives. It's almost counter to what we think about. We think of something being dominant, there should be something in there that makes it more likely for us to be prolonged. Okay, where recessives would not. The most common blood type is the double recessive. Go figure. And it's not the more desirable to have. It's not the so-called universal. We'll get into what universal recipient. If anything, your blood's to give to people. That doesn't necessarily help you. It helps other people. Okay? So there's a lot of oddity. I guess it's in that. But if you look at the chart, effectively, they've drawn, and we always draw them this way. For surface antigens, AB blood does not make any antibodies. It's about the antigen. You respond to whatever your body perceives as foreign antigens. If it wasn't there at birth, your immune system spots one of those and goes nuts. It's an all-out attack, invasion from Mars. Boom! And slews, untold numbers of aggressive white blood cells go after it, like ants at a picnic. They're on the attack. So the reason why this is erroneously considered the universal is it has both the A and B antibodies. Those are, and people thought those were the only antibodies until they figured out that the RH, so here I've drawn A, here I've drawn B, but this is the RH antibody. The true universal recipient, because you've got to have all the antigens. I misspoke, I said antibodies. So you would have antigens to A, B, and the RH antigen, which is sometimes called factor D. That's the true universal recipient, because any blood that you get, already have, your body is acquainted, as it were, with that particular antigen. By the same token, O blood has no antigen. That's why people thought it was the universal donor, but that's not true. Because if it was O positive, now you have potentially a foreign antigen that your body reacts vigorously to. So the true universal donor for negative. That's what you see at a hospital when someone has that major traumatic event. When they come in the emergency room and they're bleeding all over the place and you're going to lose them, you immediately start pushing as much O-neg as you can get into them. You'll hear them howl. I need 4 units of O-neg, get in touch with the blood bank, take them up to OR, and type and cross-match for type-specific blood, on standby for OR. That's what you do. Yes, ma'am.
So the real universal recipient would be
AB positive, and a real universal donor would be O-neg. And indeed, negative blood, because only 10 to 15% of people have any negative, you're negative in the blood bank, and you've donated blood, you're their buddy. They'll be calling you. They'll be looking for it. Let's go out on a date together. By the way, we'll take some of your blood while you're here. We'll give you a cookie, a little bit of orange juice. When we were in college, I told the other class, we used to donate blood regularly for money. You got like $15. And back, 55 years ago, it was a lot of money. I know, a long time ago. This t-shirt's probably 55 years old. Yes, we used to joke around. You see some of these, some of my friends back in the day would date women who were considerably younger, and I meet so-and-so, and they walk away, and I turn around and go, they have clothes older than she is. I mentioned about my daughter dating older, not now, not the guy she married. It's like 4 years. She dated some guy who was like my age. Sugar. Okay. Oh, I can get her to get you the website. I didn't say that. I'm only joking. Ignore me. You ignore me anyway. So that's the idea. So that's what happens, why we're so concerned about this. So there are a lot of different factors, but D is the big player. You can see 85%. Big thing is something called erythroblastosis fetalis, and the only people who are at risk are people who are women with negative, with an RH factor of negative, who want to have kids. That's the problem. Because understand, antigens don't cross the placental barrier, antibodies do. In micro, you're going to learn about viruses that cross. We talked about rubella. That's a virus that crosses the placental barrier. Syphilis is a bacteria that crosses the placental barrier. Antigens on red blood cells do not, but the antibodies do. So if a woman who is O neg carries an O positive baby, which is very likely statistically, okay, unless whoever her partner is also is homozygous, negative, etc., then there's a much greater likelihood, 3-to-1 likelihood, that the baby's going to have a positive RH factor. At the time that pregnancy ends, erroneously, it is not when the birth occurs, because whether there is an abortion, hopefully not, when there is a spontaneous abortion, like a miscarriage, perhaps so, that happens 2 out of 9 times. Maybe the baby is stillborn. Maybe there is some inherent problem right after birth. Whatever the situation, at that point, the mom's blood has been exposed to the baby's blood. And at that point, she will start to make antibodies. And those antibodies against that RH positive are going to have an impact on any future pregnancies, particularly those where it's RH positive, particularly. It's called erythroblastosis fetalis. First pregnancy, it's not about baby born healthy. It's just about whatever. It's better expressed in the way they do it on the PowerPoint. So the second pregnancies, those RH antibodies cross the placenta, destroy the baby's if it's an RH positive baby, they destroy that baby's red blood cells. The baby's unlikely to survive. Okay, now we have, and every doctor is aware of it. Everybody, whether it's a doctor, whether it's a nurse practitioner, or my daughter had her daughter way back in 2001. She had a nurse practitioner handle the whole pregnancy over at McGee because her insurance was limited, et cetera, did a wonderful job. So anybody who is the healthcare provider, whether a nurse practitioner, a physician, or whomever, will be totally aware of that situation. My daughter did not have that situation. So that we now have things to do it. Rogam has been around for a long time. That contains this anti-RH that can prevent the RH negative mom from becoming sensitized. So I don't know what the treatment parameters or what the process of treating it is, but suffice it to say it's well known. So any mismatched blood, you're particularly looking at clogging the kidneys because of hemoglobin in the bloodstream, as well as these other factors. Fever is what you look for the most. Whenever I had all these transfusions, they always, Lou, go home, check your temperature once an hour for the next 4 or 6 hours. However, I never had a reaction. It's fortunate. Again, I had relatively easy matchable blood that was there. And so this is the autologous would be self-transfusions. And the cross match is technically what you do when you're trying to determine. So you'll say type and cross match. You only have to type blood one time in the hospital. After that, just cross match. Because that you have to do every time there's a subsequent transfusion. The type, no one's blood type is going to magically change. Maybe these days with bone marrow transplantation, that may not be absolutely true, but otherwise, we'll think of those little speckle patterns of agglutination that were there. There's just about blood tests. So, that ends the blood unit. So it gives me a minute. I know you had heart, and really our focus is going to be starting about here. So you can see we went through I didn't go through them. I was trying to show the other class that, these first roughly 24 or so slides in the PowerPoint sequence, we don't have to go. I'm sure you did this in lab, correct? And I hate to rebuild the wheel. I mean, it's something I will go over, but I just want to give you a little brief introduction about this. That's what I was trying to show up there. It's this remarkable structure. It's nothing more than a pump. See, unlike when we talk about the immune system, you're going to learn about the lymphatic system. That is not a closed system. The lymphatics pick up debris, sometimes infections. They have open-ended tubes in the tissue, and eventually they feed them back into the bloodstream. Bloodstream's unlike that. It's a continuous, it's like you had one big tube starting in here, all the way to your body, and you have a parallel big tube that goes all the way to your lungs and back. We call them the pulmonary circuit and the systemic circuit. And around the focal point where these two, when I say close, they're continuous. There's no little openings. The only little openings are capillary beds. Even though that tube stays intact, there's little clefts that nutrients can go out of, waste products can come into, oxygen and carbon dioxide can fit through the membranes anyway. You don't need much of an invitation. And that structure that surrounds it is the pump. It's nothing more than an elaborate blood vessel that's got this massively thick amount of muscular tissue that pumps, here we go again, for the 800th time, more rapidly than once a second every single. That's sure. And we have to take care of it, which is why my wife has dragged me back to the gym these last couple of days on the treadmill. She advised me to get my skinny mule, using another term for that, to the gym. Not a corpulent mule, but a skinny mule. She thinks I have a skinny posterior, derriere, back of the front, fleshy part, permanent vertical smile, famous song and story. Buttocks. But she insisted. And again, as you all know, I know how to respond to that kind of intimidation. Yes, dear. When are we going, dear? I'll get my sneakers on. Let me change into my gym outfit. Or else. So, I don't care about the shape. It's a pump. And the blood, if we just learned, contains everything. Dissolved gases, nutrients, waste products, oxygen and carbon dioxide, principal dissolved gases. Arteries, I'm sure you learned that. Doesn't mean oxygen in blood. It means away from the heart. Veins, back to the heart. The only blood vessels, pulmonary artery, venous blood, pulmonary vein, arterial blood. The only difference is the umbilical, the fetal circulation has that as well. But typically our context is less fetal than adult. So I will, typically if I ask you a question like that, you'll frame it in the adult, comma, and then you don't have to worry about the umbilical, stuff like this. Pulmonary and systemic, pretty straightforward. It's a double-sided pump that does the same thing. You dissected the heart in lab. You have atria on top and ventricles underneath. The atria, there's nothing about them. It's an opening. It has minimal muscularity, and basically 80% of the time, the blood just flows into the atria and back down to the ventricles immediately. Because it's an open. Remember those atrioventricular valves, tricuspid, bicuspid, they're open. So the blood just flows in. That other limited amount of time, when the atria contract, they do so for one reason, to top off the tank. When you go to the gas station and says, please don't top off, the heart never heard about that. So the whole idea is they maximally fill the ventricles. That's their job. So you have the atria on top, the ventricles on the bottom. It's a side-by-side system. So it's a two-stroke pump with the atria squeezing it, filling the ventricles, and the ventricles pumping the blood out aggressively, whether to the lung system or the body system. And it's side by side. The right side handles the pulmonary, the left side handles the body. So it's a two-stroke pump and a double-sided pump. And the big problem with that is everything is fine unless there's inequality. Because if one side isn't doing its job, eventually it's going to cause the other side to work extra hard. So if one side fails, believe me, the other side is going to fail right after. So you're going to hear a lot about that when we talk about the physiology. It's all about that symmetry. Bodies are about symmetry. So the blood isn't getting to the lungs. All the heart knows, I'm not getting enough oxygen. It's going to work extra hard, and eventually it's going to fail. Then it fails, and the blood can't get to the lungs at all. Then that side's going to fail. And when that happens, that's complete heart failure, and people often just don't survive that. So those two circuits that are there, obviously oxygen poor versus, it's good not to say deoxygenated, because as you'll learn in this and in a chapter on blood pressure, you only give up about a quarter of the oxygen routinely. The blood in your veins has probably 3/4 of the oxygen the blood in your arteries that are there. So, I mean, you'll see this diagram again. I'm not going to revisit the blood vessels. I expect you to know where the superior vena cava is and the pulmonary artery here, or pulmonary trunk, the right and left arteries, the aorta, all those wonderful. Why do they call it a mitral valve? You have tricuspid. Why is the bicuspid a mitral valve? Terrible. What's a miter? M-I-T-R-E. I don't know. Lou, what's the matter with you? Groucho Marx. So, you know, the Jewish guy knows this. Do you play chess? You know what the chess pieces are? The bishop. What's distinctive about the bishop? He's got a hat, pointy hat. Could be a dunce cap. Okay, it's the bit in the Catholic Church. Any bishop has two items of authority: their staff and their mitre. That's the hat. It's got the pointy top. They named the mitral valve bicuspid valve because it appeared to have that shape. What did they know? Okay, the Pope has that hat. Right now, the Pope's pretty sick, but the Pope, he's the Bishop of Rome. He's a Jewish guy. I know, it's amazing. So you know the atrioventricular valves, the aortic and pulmonary valves, what they do, and you need to know those because we're going to get into the heart sounds and the cycle itself and the electrocardiogram, which we'll do a lot on it. With any good luck, I can do a pretty good sized demo with this. So this is all standard stuff. I don't care about the numbers. If there's anything anatomical, I'll specify it. You can see these are those divides areas, those septa are where you find the coronary arteries and then cardiac veins. And here you can see the location, et cetera, et cetera. We'll stop it there. Whatever I need to cover, I will cover with you subsequently. So see everybody Wednesday. Thank you. Oh, man, get back. Just cracked my neck.